So this is the Elita smooth as silk, and this is the machine as it looks. So those who have seen the interlace, this is far more compact than the interlace, and there are two screens on it, one here for the surgeon and this is here for your this is there for the assistant. Now what you see here is that it gives the flap, as I told you, in 16.6 seconds. It is an ultra precise pulse which you can see. Continuous surface scanning. So this you can see is that a continuous surface scanning. So it scans the surface continuously and you have a 1 micron spot which is there. And this sub-micron precision is got because of the high numerical aperture focusing optics. So this is very, very important. And there is also an auto Z detector which is there and multi-channel beam splitter. So what this does is that you can get very small spots absolutely uniform and where you want them to be placed. So this is what the engineers of J&J claim to be there. Now if you compare the Elita with the IFS, you can see that the pulse duration has gone down to about an average of only 150 femtoseconds. So that's the fastest, the shortest pulse that you are having. Pulse frequency is very high, which is 10 megahertz. The spot size, as I told you, is only 1.3 microns. The wavelength is 1040, as we know. So if we compare the Visumax, this is the comparison with the Visumax 500, not with the 800, and IFS. So from 600, 800, which is femtosecond, which is the intralace, you have gone down to only about an average of about 150 femtoseconds that is there. And the pulse energy is significantly down, and this is actually the lowest pulse energy that goes in the Elita system as compared to any other system. So what is the thought process? The thought process is that supposing you have a paper like this and you have, say, a 4 micron separation, and you have a paper like this where you have a 1 micron separation, just a simple kind of description. So you see it's a postage stamp. If it is not perforated properly, you will see that the dissection is going to be requiring something which you may not see when you are doing a 1 micron which is coming next to each other. So smooth incision lenticular extraction is considered to be a next generation lenticular procedure. Indications are up to -12. With sum and sphere of cylinder going up to 12, -1 to -12, minus cylinder you can go up to 6. Biconvex lenticule is something that we will be talking about. 16 seconds what it takes, and cyclotorsion and docking centration are there. This is the same video that I showed you, where I showed you that you can center, as also you can do a cyclotorsion adjustment. This is the removal. Now when we did the study was based on, the first thing in the study was to start and see that a flap is doable. So that was started in 2018, and then there was energy optimization and thing, and we got as good flaps as we got with the intralace, actually better looking flaps, but statistically the visual outcome was not any different between what you had with the intralace versus this. Then on 5th of January, when the COVID had struck, it was really difficult, and it was online 6-7 cameras from US, East Coast, West Coast, and Delhi that we were able to do this. So first phase we looked at amblyopic patients, and we would take patients and see whether the lenticule was doable or not. That's the first thing. And then we looked at the vision outcome. And then on we went to one eye at a time, and then we went on to both eyes at a time. And now there's a limited market release with some people that you can do it clinically any place which is there. These are the normal indications, contraindications which is there. So these are the study design. They started out in Center for Sight Delhi and then went on to NN, and now there are multiple sites in Europe, as also in Hong Kong, as also in Korea, which are giving out the data. And the mean endpoints were the MRSC, the UCVA, and the best corrected spectacle visual acuity. Now, when you look at the study results, surgeons rated the ease of lenticle removal as no or mild dissection. So basically, if it is less than 25% requirement over an area, we would call it as no, and mild would be less than 50% requiring dissection. So you can see that the dissection requirement was absolutely minimal. That's one thing. So that is why we never had any retained lenticules. Uncorrected visual acuity of 20/20 or better was got in 96% of the patients at 6 months, and it is higher still when we are looking at 1 year. So there is very little case of regression. We have not retreated any one of them. and the MRSC was within plus minus 0.5 in 91% of the eyes at 6 months. Subjects were slightly undercorrected on average, and as Shri also knows that there was a nomogram adjustment that we did for these eyes. Similarly, there is a nomogram adjustment 1 and nomogram adjustment 2 that we have done on the Elita system, whereas there is a slight overcorrection of minus 0.25 plus 10% of what it is. So you can see here, this is the intended versus achieved that you see. So there is an undercorrection as you are seeing. And this is the phase 3. As you can see, it is only in the higher myopes that we are having the undercorrection, and now we have also done a second nomogram adjustment in which the results even for high myopia are tighter. So there is by far in majority of the lenticules a slight undercorrection which you have to do a nomogram adjustment. So now this is a standard nomogram that we are having. Every nomogram is actually based on the Mullrich formula. So there is one wrong concept that lenticules take more thickness as compared to excimer. No, the only place where lenticule take more thickness is that you have to have a flat ad or a table which may be about 10 microns. So in a one diopter or two diopters, which really doesn't matter, you may be actually making the lenticule about 40 to 50 microns as a minimum thickness to actually work on it. But normally when you're going to 6, 7, 8, it translates to only 2 microns or something more per diopter. So this is at 9 months, you have 90% of the eyes MRSC within plus minus half and 94% at 12 months. So this was in the phase 1, phase 2 as we have gone on. Easy and smooth lenticular extraction was 91% of the patients that you had. This is just to show you the post-op cornea clarity on day 1. And one of the things which NN has worked upon, and this is a Chinese paper, is that because of the lenticule being curved, the patient interface being curved, the way the whole lenticule is taken out in a plano-convex is that there are these micro distortions that happen in the Bowmans, and they persist up to 3 years for myopia, and this causes what is known as the scatter and a drop in the visual acuity. The confocal microscope with the biconvex lenticule that has been made, you know that all camera lenses etc. are biconvex lenses because they induce the least amount of aberrations. So having a biconvex lenticule makes much more sense than it is. The other thing is that if you are having a plano lenticule, plano convex, it will cut the nerves right at the start of the plane. But when you are having like a knob which is coming, so the nerves go, and again, and then has done some studies to say that though the dry eye induction is less in lenticules, it is still less as compared to Visumax in the SMILE patients. And this is to show you the mean higher order aberrations again, which has been shown that the induction, this is by Rushad Shroff, that the induction is much less in the lenticule based procedure of the Elita. It has not been compared with the Visumax, but this overall the induction of aberrations are much less when you are looking at a biconvex lenticule which is there. My personal impression is that the silk lives up to its name of smooth incision lenticular keratomiliosis with minor or no tissue adhesions. All cases had complete lenticular removal, as I told you. Just if you keep the cornea moist before firing the laser, you do not get any cold spots and any uncut areas. Plane identification is relatively very easy. Entry into the side cut is perfect because it goes like you're putting a knife through hot butter. Corneal biomicroscopy was unremarkable on day 1. Visual acuity was pretty good. Most of our cases, and at NN, more than 90% of the cases are getting 20/20 vision day 1. Refractive correction is pretty accurate, tight outcomes, and patient satisfaction on the Prowl questionnaire was found to be more than 97% of the patients giving a satisfaction rate that they are happy with the procedure. Future developments, as we know, from a 2-piece PI within the next 6 months or 8 months, you never know with these trials. The docking trials are on in US, and then it will come to us to use a single-piece PI. So it will be similar to the Visumax, a single-piece PI. The second thing is hyperopia, which is going to be there. And then a rescue flap, which may be required in the thing. I don't think engineerically it may be possible because both are refractive surfaces that you can go and cut into the same refractive convex surface if you do suction at before in these particular cases that you can restart or redock a lenticle at the same time. So these are what we expect to happen over time, and further energy optimization is something I think, and the results and nomograms would be the other things which will make this machine perfect. So that's all that I'll wish to say. Thank you very much for your kind attention. This is just tips and pearl for outcomes, our proper instrument identifying the plane. The only difference is in a plano-convex, you can actually go in like this. Here you have to go in like this because it's a biconvex surface. So that's the plane identification which is there. And otherwise, head position is important because you don't want the nose sticking in. And good centration and cyclotorsion compensation should be done by marking properly. So this is the new generational leap, I would say, in corneal refractive surgery with outstanding patient outcomes, highly accurate flap thickness, with smooth stromal beds and easy lifts, and lenticule is performing pretty well. Thank you very much for your kind attention. Any questions? Anyone? Yeah. Yeah, we have done minus 0.5 sphere with 4.5 this thing, and in 2 eyes of the same patient, in one eye he was 20/20, in the other eye there was a residual cylinder of about 1 or something like that, 0.75, but the results are... See, the only thing is that we don't have a plus minus. If you have a compound power, the nomogram doesn't allow you to treat, but we are doing high cylinders. I was even with the Visumax 500 after marking and changing the alignment, I was doing it. He has done a study, and I am not apprehensive in doing high cylinders in the silk. Yeah, go ahead.
If you have a pure cylinder, then you cannot treat it with smile. You need a minimum of 0.5 sphere 0.5 in the commercial software. But in the non-commercial software, I have treated pure cylinders also. I've also done mixed astigmatism. We have the first results which were submitted to IGO for publication for mixed astigmatism, smile for mixed astigmatism, and results are fairly good. So you can do astigmatism. It's not that you can't do, but you need to have the cyclotorsion compensation, then you get better results.
So that's what he said, that you need a minimum 0.5. You can't do if you have plus minus. And
the other clarification about micro distortions in the Bowmans, I think it's more of your technique of removing the lenticule, because when you put an instrument and you're actually pushing it around, then you actually stretch the Bowmans. When you stretch the Bowmans, you have Bowmans folds. So irrespective of which laser you use, if you're stretching the Bowmans, you will get Bowmans folds. Now if your dissection is very good, you're not pushing against the edge there, then you will not get in. I have a technique, I described a technique of no dissection, where you just pull out the lenticule, and in that we don't see any, because even with some of them have described ironing of the cap and all that, but I don't do any ironing. And if you look at my OSIs on day 1, it's less than 1.5. I showed you some examples, it's like 0.6. So when you have microfolds in the Bowmans, that increases the scatter and reduces the quality of vision. But again, I think it is about your energy optimization and your surgical technique more than the interface.
So, but the point is that this study out of China, and there are others, which is, this is 3 years post-surgery.
A study is, again, it depends on the methodology, right? If they have used dissection, and then if the dissection is rough, then you will get micro folds.
Okay, but suffice to say that these micro folds are important for reducing the quality of vision, and that if he has satisfactory evidence to say that it's totally dependent on the dissection techniques, then that's, and the energy level, then that's really good.
What I feel is that how much dissection you need to do is very significant, because if you have very little adhesions, then you will not do much dissection, and then the folds and all such irregularities in the interface are much less. So
thank you very much.